جميعا. Before I start, I'd like to thank the organizing team. I was impressed with the organization, the level of communication, as well as what I've seen so far. Also, I'd like to thank you for and commend you for coming during the weekend, leaving your weekend and coming to at least hear something maybe different than what we usually hear in pharmacy gatherings. And the third thing is thank Dr. Dalal for making my talk easier. I work with Dr. Dalal at King Faisal Specialist Hospital. I'm not an elegant speaker like her though, but I'll try to share with you some of the important information about transplantation and the use of medications. Now, I'm sure that Dr. Dalal told you about the importance of pharmacists. And when I talk about pharmacists, not particularly clinical pharmacists, working with patients in general, and in particular with high-risk groups. One of the high-risk groups is organ transplant patients. Those patients are difficult patients in terms of their medical conditions. They have gone through very difficult times during their chronic disease or end-stage organ failure, whether it's kidney, liver, pancreas, or lung, or heart, and they have suffered enough, and they see organ transplant as their final solution, and it is. The treatment of choice for any organ failure is organ transplantation. We could support patients during their chronic diseases or end-stage organ disease, but ultimately they either have to receive an organ transplant, for example, kidney or liver, or they have to suffer from chronic morbidities and unfortunately mortalities. So my understanding of this gathering is going to be more of a workshop. So I like participation, and I like to have it as interactive as much as possible. These are the objectives of my talk. I'm going to review very summarized, very basic stuff about organ transplant for those who have not read about them. Can I take hands? Who has studied this? Are you all from King Saud University, by the way? No. No? Okay, good. So how many students do we have? Students. Okay, majority students. Pharmacists? Okay, few pharmacists. Good. So have you studied about organ transplantation during your undergraduate?
Yes.
Okay, good. Excellent. And you had then covered the immunosuppressive agents? Good, excellent. So that makes it very easy. So let's go over our objectives. We'll start with basics of solid organ transplant, types of immunosuppressive agents. Dr. Dalal touched on some of them. General review of the pharmacokinetics, pharmacodynamics of these important immunosuppressive agents, main side effects and drug interactions. And if we have time, we'll discuss 3 quick cases related to immunosuppression and organ transplant. So we don't have slide changes, huh? Okay, so I'll stay here until we have something to discuss in a long time. So we'll start with the goals of transplant. Why do we transplant patients? I mentioned early on that this is the ultimate final solution for organ failure, right? We transplant patients for 3 main reasons. The most important reason is improving patient or increasing patient life or decreasing mortality. Those patients who suffer from chronic kidney disease, for example, or end-stage liver disease, for example, they have actually lower survival rates. So if you compare a patient who's on hemodialysis versus kidney transplant patient, their survival is much higher with kidney transplant. And this has been documented in many studies. For some organ transplant like liver and lung, heart, this is the only solution available. We do not have heart dialysis or liver dialysis or lung dialysis like kidney, for example. We have some supportive measures once they reach their liver failure or lung failure or heart, for example, like LVADs and other VADs. But these are very temporary. You really have to transplant the patient as soon as possible, otherwise the patient will die. So number one is to improve patient survival and graft survival. And when we say graft, we mean the grafted organ, the transplanted organ. And then the second goal is to prevent acute rejection. And this is why we give immunosuppressive agents, initially at least. And then lastly is to minimize drug-related toxicities or post-transplant complications. And there are many complications. There are multiple factors that affect the grafted organ success. I'm not going to go deep, but there are multiple factors, including the number of previous transplants. So the more organs that the patient received before puts the patient at higher risk of rejection and ultimately graft loss. Patients who have early graft dysfunction, so after we transplant kidney, for example, or liver, and the kidney does not function immediately, this is a bad sign. Usually it correlates with higher incidence of acute rejection. This might not be true in other organs, but some other organs have the same problem. So a liver transplant, for example, early acute rejection, for example, is not very important. But in general, the more or the fast the organ functions immediately after transplant, the better outcomes. We have something we call delayed graft function, whether it's liver or kidney, and this is usually not a good sign for us. Delayed acute rejection, as I mentioned, if we have early acute rejection, at least in kidney transplant, is associated with higher risk of further kidney rejections and organ dysfunction. Patients who are previously sensitized, so and we get sensitized from so many factors, from the environment, blood transfusion. Those patients on chronic kidney disease, on hemodialysis, they lose a lot of blood. We know that they have chronic anemia of kidney disease, or anemia of chronic kidney disease. So they need a lot of erythrocyte-stimulating agents. Sometimes they lose blood during dialysis, so we give them blood. We sensitize them by giving them foreign antigens from different people. Okay, so this blood is coming. This blood contains cells, right? Contains blood cells, red blood cells, platelets, and all of these come from different people. So these are considered foreign antigens. So you sensitize your patient by giving them blood. Pregnancy is another sensitization factor. So the more number of pregnancies, the higher risk of sensitization, and this puts the patient at higher risk of rejection. Some races, African Americans, blacks, usually tend to reject more, and the reason for this is not very well understood. Some other races, they tend to reject less. Here we are in the middle between Caucasians and blacks. HLA match, which is important in many organ transplants, also is very important. That's why we get HLA matching between the recipient and the donor. And we cross-match the patient with the donor, whether that donor is deceased donor or what we call brain-dead donor, or living donor. So all of these have impact on the quality of the organ, transplanted organ, as well as the long-term function. We have multiple types of rejection. So we know that by transplanting an organ, we at least get rid of the damaged organ, let's say, the failed organ, and we put a new one. But that new one is viewed by the human immune system as a foreign body. Doesn't differentiate between an organ that's supposed to work fine and help the patient and bacteria, for example, or virus that is non-self, we call it. So it tries to attack it. And attacking the transplanted organ via multiple immune mechanisms might result in transplanted organ failure, or not failure, but rejection. And there is a difference between organ failure and organ rejection. This is very important to differentiate between the two. So transplanted organ rejection means that there is an inflammatory, strong inflammatory process usually carried out by T cells attacking that organ. And this does not mean necessarily that the organ will fail, because we have now very good ways, including strong medications, of treating that acute rejection. So if you treat acute rejection, you can actually return the normal function or the baseline function of the organ back to the patient. If that acute rejection is not treated, it might lead to chronic rejection and ultimately organ failure. So organ failure means that the organ does not function again, and we call it graft loss. Graft loss means that the patient will need another transplant. Graft rejection means that we need to treat that rejection to preserve that graft. Okay? So we have different types of rejections. We have what we call, the first one, hyperacute rejection, and one in a while. And the reason is this hyperacute rejection occurs as a result of immediate antibody attack to the grafted organ. And this is a result of preformed antibodies in the patient against that particular organ. So the human body does not need to produce or manufacture antibodies against that graft, or that patient has already preformed antibodies. So the minute you put the organ in the patient, these antibodies will attack the organ and it will kill it. Okay? And you see this within a few minutes or a few hours. And many times you see it inside the operating room before they close the patient. The kidney will turn black, okay, blue and then black, and then necrotic immediately in front of the eyes of the surgeon. We do not see this anymore because we do what we call cross-matching. We make sure that the patient does not have antibodies against that particular donor's antigens, okay? And nobody should go to transplant before having cross-match. Now with the new techniques and strong immunosuppression that we have, we're able to transplant patients with cross-match, patients with positive cross-match. So in the past, we used to tell patients, if they cross-match positive, that this organ does not work for you, go home, okay? And we cannot transplant you. Now we have what we call desensitization techniques, where we can get rid of these antibodies and then put the patient on strong immunosuppression, strong agents to prevent production of these antibodies again. The second type is called accelerated, and accelerated is not antibody mediated. This one is T cell mediated, and it generally does not respond, but we have been able to recover some accelerated rejections. Usually it happens within a few days, 2 to 3 days, okay? And this is very strong reaction, T-cell mediated reaction to the grafted organ. And the reason that it does not really respond is the the strong reaction that happens occurs really fast to the degree it does not allow does not give us time to reverse the process. It's not that we do not have strong medications that work on preventing the T cell activation, for example, or destruction of T cells. It's a time issue. The most common rejection type is called acute rejection, and this is what we mainly use medications or immunosuppressive agents for. Usually it happens within 6 to 12 months before, after transplantation. It responds usually to anti-rejection medications, and it's T-cell mediated again. Chronic is really complicated subject. Many people think that there are many factors other than immune-related factors in chronic rejection, and this is really evolving and rapidly changing discipline where we learn things almost every day about chronic rejection. So there are, in summary, we could say there are immunological related factors as well as non-immunological factors. And usually does not respond to anti-rejection medications. So this is characterized by a gradual decline of the organ function over time. It's not sudden, it's not like acute. So you see the patient, usually it happens after 12 months. You could see it sometimes earlier in highly sensitized patients. And it's a gradual decline of organ function over months before the organ fails completely. So how do we diagnose rejection? We need to apply differential diagnosis methods. The most important thing is to rule out other common factors. So those patients, let's take kidney transplant as an example. We need to rule out drug toxicity, for example. Some of the immunosuppressive agents that we use are actually nephrotoxic. So if we use more medications, that's why Dr. Dalal mentioned that these medications need to be monitored, their levels need to be monitored, and we apply what we call therapeutic drug monitoring on many immunosuppressive agents, because we do not want to over-immunosuppress or under-immunosuppress. These agents have nephrotoxicity potentials. If we give too much, you can end up having nephrotoxicity, and it will show as elevation in creatinine, reduction in kidney function and GFR, and you would think, oh, the patient is rejecting. Then you need to rule out this first before you think of rejection. Is this clear? Yes. Okay. Second is, and this is very important, especially immediately post-operation, is vascular complication or surgical complications. One of the most important things is thrombosis. And surgeons worry about it very much. If there is a sudden deterioration in organ function immediately post-operation, the first thing to rule out is vascular complication. If there is vascular stricture, if there is vascular thrombosis, and this needs to be done through ultrasound, MRIs, and sometimes CTs to make sure that there is no thrombosis. And if there is thrombosis, you need to take the patient immediately to the operating room and remove that thrombosis, put the patient on anticoagulant, otherwise you can lose the graft very fast. Third is infection. So let's say liver transplant, okay? Patients who undergo liver transplant, they can develop what we call cholangitis. And it's part of the infection of the biliary tract, and it can show as elevation of liver enzymes. So we might say, okay, well, patient just got transplanted, now liver enzymes are up, patient might be rejected. We need to rule out infection before. Same thing for kidney. Patient can have urinary tract infection or pyelonephritis, and this also will reduce GFR, increase serum creatinine. The last thing to roll out before we confirm diagnosis of rejection is recurrence of disease. And this applies to all organ transplants. I'm just giving you examples. So for example, kidney, we know that some of the baseline diseases that led to chronic renal failure or end-stage renal failure can recur after transplant. So something like IgA nephropathy, certain interstitial diseases, they can actually recur in the transplanted kidney. Same thing for kidney, for liver transplant or heart. For liver, for example, hepatitis C, hepatitis B, they can return after the transplant, and this will show as elevation of liver enzymes, elevation of bilirubin and others, and you might think the patient is rejecting, while actually the patient is having a recurrence of the disease. So first, rule out these things. How? What's the gold standard? Biopsy. So we take a biopsy from the organ. Could be heart, could be lung, could be liver or kidney or pancreas or whatever. And this is the most definitive way of diagnosis. The pathologist will be able to look at the biopsy and tell you that the patient is having most probably a recurrence of hepatitis C or antibody-mediated rejection or thrombosis or whatever. So that's the most definitive diagnostic procedure. So let's talk about immunosuppression. In the past, we used to have only very few immunosuppressive agents. So anybody who came for transplant, we used to give them the same regimen. And the success rate was not great, unfortunately. So the first organ transplant that happened in South Africa, well, it was not in South Africa, the first successful was actually in the United States, was a kidney transplant in 1954 from identical twins. And they did not need much immunosuppression, and that's why it actually succeeded. The most troublesome issue at that time was availability of strong immunosuppressive agents that will not kill the patient. Because we could immune suppress the patient, but using very strong techniques that will lead to major complications. So early on, we used to give, for example, total body irradiation. Okay, patient can die before we transplant. Strong alkylating agents, chemo agents like cyclophosphamide. Okay, very high doses. But the beginning of immunosuppressive was actually with the use of steroids, corticosteroids. At that time, we used to have only corticosteroids, some cyclophosphamide, and total body irradiation, and that's it. So the success rate was not that good. That's why organ transplant was not common during these times. Now, starting 1962, when azathioprine, which is an anti-proliferative agent, came out, and it was used with corticosteroids in 1963, it actually improved or reduced chronic, acute rejection. But again, the results were not marvelous. We used to have about 80% or 70% rejection rate, which was a lot. 1966, we started having anti-lymphocytes, sera, from the University of Minnesota in the United States, and they used to get the anti-lymphocyte sera from goats. So they used to manufacture them in the university. There was no manufacturer at that time. Then 1970, further delay. Let's go over the immunosuppressive agents really quick. We have different classes. We have what we call polyclonal antibodies or anti-thymocyte globulin. Sometimes they're called anti-lymphocyte globulins. I like the anti-lymphocyte globulins because they are not actually anti-thymocytes. They work on the lymphocytes, including T and B sometimes. And these are, they come from different sources, rabbit source, Coletrapid, ATG. We have two different kinds of rabbits. They come from horse, or equine, we call it sometimes, horse origin. The goat is not used anymore because of the high risk of hypersensitivity. It's obsolete. Then we have the monoclonal antibodies, and we have different types of monoclonal antibodies. We have the neuromonab CD3, anti-CD3, we have the IL-2, anti-CD25, and we have the alemtuzumab or Campat, which is anti-CD52. Then we have steroids, corticosteroids, methylprednisolone and prednisolone. And then we have CNIs or calcineurin inhibitors like cyclosporin and tacrolimus. We have the inhibitors of target of rapamycin, mammalian target of rapamycin inhibitors, mTOR inhibitors, like sirolimus, everolimus. Also antiproliferative drugs including MPA derivatives, mycophenolic acid derivatives, or like mycophenolate mofetil or mycophenolic sodium. And then azathioprine, which is the older Imuram antiproliferative agent. Then we have the newer class called selective T-cell co-stimulation blocker, or CTLA4 antagonist, and this is called belatacept. Then we have other new drugs under development. So for immunosuppressive regimens, we have three different types, and I want to clarify this because this is very important. We have what we call induction agents, so we induce with these agents. And then we have the maintenance agents. We put the patient on maintenance, immunosuppressive agents. And then we have what we call agents for treatment of rejection, anti-rejection medications. Okay? So induction, upon transplant, just before transplant, when we take the patient to the operating room, we give huge doses, not huge, but I mean we give strong medications at least, with good doses to prevent the accelerated rejection, if you remember, the accelerated rejection, not the hyperacute. Hyperacute, we cannot prevent it this way, okay? And to prevent acute rejection in the first few months, and also to allow the delay of introducing some maintenance immunosuppressive agents that are not favored to be introduced in the early post-operative or post-transplant stage. Maintenance, we put the patient, we send them home on these medications. Usually they are oral medications with some exceptions. And then treatment, God forbid, if the patient develops rejection, then we have to treat that rejection with anti-rejection medications. And the list of medications or classes that I talked about a few minutes ago, or listed, are used in different ways. So some of them are used only in maintenance, some of them are used only as induction agents, and some of them are used in different ways. So, for example, polyclonal antibodies are used for induction and also used for treatment of rejection, okay? But they're not used as maintenance agents. Monoclonal antibodies are used for induction, and we used to have one monoclonal antibody that was used for treatment of rejection, but it was withdrawn, which is RKT3. Now, another monoclonal antibody, alemtuzumab, we're going to talk about it. It's not really licensed for transplant, so that's why I did not check it for treatment of rejection. Then we have corticosteroids. Corticosteroids are actually universal medications, so they can be used, they are actually used for induction, for maintenance, and for treatment of rejection. Despite the bad reputation of steroids, they're actually very useful for all of these different types of immunosuppressive strategies. CNIs or calcineurin inhibitors are used mainly for maintenance. There are some questions or some debates about the use of FK in particular, or tacrolimus in particular, for treatment of rejection, especially in liver transplant. mTOR, maintenance, antiproliferative, and CTLA4 blockers are all for maintenance immunosuppression. So who should get the induction? High-risk patients. We talked about this. So high-risk patients, this is individualization. This is what we call individualization. So high-risk patients, they should get induction. With what type? Also, you need to qualify their high-risk statement. So you should, not every patient who's labeled as high-risk is as high-risk as the other patient, okay? So they vary. So very high-risk patients, they should get very strong induction agents like anti-thymocyte globulins. Patients who are moderate risk, they should get something like IL-2 receptor antagonists. Patients who are not high risk, they should not get induction. Okay? طبعا, there is no black and white here. It's a very gray area. So you will see different centers using different protocols. They develop these protocols based on their understanding of the best available evidence. And there isn't many, unfortunately, in the transplant area. And they develop their protocol. So some centers, they induce everybody, regardless. Okay? But then they individualize the maintenance. So they induce even low risk, but then they avoid or minimize steroids on those low risk patients. And they induce high risk patients, but they do not avoid or minimize steroids in those high risk patients. So that's another strategy. Okay? But the concept is the same, individualization. So those are the high-risk patients, pre-transplant, pediatric patients. Pediatrics tend to reject more than elderly patients, high PRA patients, or panel-reactive antibody patients, African Americans, patients with long ischemia, cold time, or cold ischemia time, recipients of organs with marginal donors, and other transplant or other organs. So even the organs themselves are not equal in terms of their ability to reject or risk of rejection. So, for example, small bowel transplant, they reject much higher than any other organ. Lung transplant are very high risk for rejection. Pancreas transplant, followed by heart and kidney, followed by liver. So liver is the least organ. It's the most immune tolerant organ, or the least immunogenic organ compared to other organs. So also this plays important role in designing the induction agent. So we induce with anti-T cell therapy like polyclonal monoclonal, and we can induce with IL-2 receptor antagonist. Okay, so the message, which one should we use, depend again on the risk of rejection, but again, the side effect profile, because anti-T cell therapy they really have bad consequences in terms of infection and malignancy compared to IL-2 receptor. IL-2 receptor are not as strong in terms of prevention of rejection, but they have very favorable side effect profile compared to anti-T cell therapy. We have different mechanisms of action for these immunosuppressive agents. OKT3, which is not available anymore, was withdrawn from marketing perspective, not because of regulatory action. It works on cluster of differentiation 3 or CD3, so it's called anti-CD3. It's a mouse or murine antibody against CD3 in T cell. So it blocks what we call signal 1 activation. We have the anti-CD25 or IL-2 receptor antagonists. These are basiliximab and daclizumab. They actually block CD25, which is responsible for the activation of IL-2 receptors, or what we call signal 3, the beginning of signal 3. And then we have anti-CD52, and this is Campath or Campath 1H, or alimtuzumab. All of these agents are monoclonal, so they work on one clone, one CD, right? Some of them are very strong, like OKT3 and alemtuzumab, okay, OKT3 and alemtuzumab, they actually result into T-cell lysis. The IL-2 receptor antagonists are not strong enough to result in T-cell lysis, so they just block the activation of T-cell by blocking IL-2 receptors, okay? So the T-cell will be preserved. This is important for the side effects later on. So the other type of induction agents are called polyclonal. So they work on multiple CDs rather than one CD. So they work on CD4, CD8, and IL-2, and multiple CDs. And these are purified, pasteurized immunoglobulins against the T-cell, human T-cell. So what we do is we take human T-cells, we inject it in horses or in rabbits. We allow them to produce antibodies against them because they are considered foreign cells, so they will produce antibodies. We take these antibodies, purify them, pasteurize them, okay, formulate them in a pharmaceutical form, ready for patient administration. So that's basically what polyclonal anti-T-cell therapy like thymoglobulin or ATG. So if it comes from rabbit, it's called rabbit ATG. If it comes from horse, it's called equine ATG. In organ transplant, solid organ transplant, we prepare rabbits. In stem cell transplant and other hematological malignancies, now there is good data favoring horse ATG. So basically they work on multiple CDs, 11, 18, 25, which is IL-2, CD3, CD2, and they result in opsonization and destruction or lysis of T-cell and the release of all cytokines from the T-cell, which can lead to what we call cell in a few minutes. So they work on activated, this is important, they work on activated T-cell or not yet activated T-cell. That's why we use them for induction before they are activated to prevent their activation, okay? Because we lyse them, actually, we kill them, we destroy them, okay? And even after activation, we could lyse them and get rid of their function, right? While something like IL-2 receptor antagonists cannot be used for treatment of rejection, and the reason is they have to block IL-2, which is responsible, again, it's signal-free, responsible for the final signal for activating T-cell. So it has to prevent activation of T-cell. Now, once T-cell is activated, that IL-2 receptor is meaningless, okay? So you cannot deactivate, in other words, okay? And that's why we do not use them for treatment of rejection. Anti-thymocyte, as we said, there are rabbits and horse. We have the rabbit, there are two formulations of the rabbit. Those of you who work in hospitals, it's very important, this is very important. This might be a point for serious medication error, dispensing or prescribing error. You have to differentiate between these two forms because their dosing is different, okay, and their infusion instructions are different. So we have thymoglobulin, for example. The dose is 1.5 milligram per kilogram in organ transplant. And again, in stem cell transplant, you use much higher doses than this. So 1.5 milligram per kilogram. With ATG Fresenius, which is again rabbit, but it's manufactured by a different technique, different purification and pasteurization techniques. So it's less pure, we consider it less pure. And less potent, again. So we use higher dose. We use 4 to 6 milligram per kilogram. So imagine if you receive an order for ATG and the dose is 4 to 6 milligram and you dispense thymoglobulin. What's going to happen to the patient? Okay. Vice versa. If you receive an order for 1.5 milligram and you dispense ATG Fresenius, okay, patient can reject because this is an underdosing or subtherapeutic dose. So they are very effective in treatment of rejection. We reserve them for steroid number of side effects, including, but not limited to, infusion-related side effects. So we need to pre-medicate the patient before we give these medications. We usually pre-medicate with acetaminophen plus Tylenol, acetaminophen plus diphenhydramine. And they have what we call cytokine release because they destroy T cells, and these cytokines will be released. And this will result into hypotension, fever, rigors, chills. That's why we give the pre-medication, to prevent these things from happening. So we can continue giving them the full dose or the full duration. Another side effect, which is an extension of their pharmacological effect, is, remember, these are anti-T cells, so they work on the white blood count line, right? So they are supposed to cause lymphopenia, but they always cause leukopenia, right? Not only lymphopenia, but also neutropenia. They cause also thrombocytopenia and anemia, so they actually have bone marrow suppression effect. Also, they increase the risk of malignancy, risk of infection, viral, fungal, and bacterial infection. Usually infusing over 4 to 6 hours over the central line. We try to give them after plasmapheresis and hemodialysis in certain patients. So what do we monitor? We monitor CD in order to see if they are effective on T cell. We need to monitor certain CDs or clones, either CD3 or CD2. And we monitor what we call absolute lymphocyte count, okay, to make sure that lymphocytes are suppressed. Also, we need to monitor for side effects like platelets, white count. We need to hold the dose at certain level or decrease the dose to half at certain level of leukopenia and thrombocytopenia. IL-2 receptor antagonists like teclistamab, basiliximab. Teclistamab is no longer available, again withdrawn by the manufacturer for marketing reasons, not because of safety issues or efficacy issues. They bind to the IL-2 receptor and inhibit the T cell proliferation and activation. They're used for induction only, not for treatment of rejection. And they don't have major side effects. Some nausea, vomiting, abdominal pain, but no major side effects. And they do not tend to increase the risk of infection compared to polyclonal agents. Basiliximab is the one available. It's a chimeric, which means it's part human, part murine. Monoclonal antibody. Its T cell inhibitory effect lasts for about 30 to 55 days from a single injection. We usually give it twice. We give it just before the patient, 2 hours before the OR time, before the transplant, and then we give it on day 4. Okay. For the anti-T cell therapy, we tend to give more than 1 dose, between 3 to 5 doses, according to our monitoring of absolute lymphocyte count. So this is the dose for pediatrics and adults. The main side effects, as I said, is rare, infection. They don't tend to have many drug-drug interactions, even though there is some literature suggesting increased CNI levels. Teclistamab, I'm not going to talk about it since it's not available. OKT3, also not going to talk about it since it's not available. But alemtuzumab is not approved for organ transplantation. It's, but it's a humanized monoclonal antibody against CD52. And this is really strong that it affects all circulating T lymphocytes and causes, inhibit their circulation and also cause lysis. Alemtuzumab is, again, is not FDA approved, but it can be given as single dose or 2 doses. It can cause severe lymphopenia that can last up to 1 year. Okay, it's very strong lymphopenic agent. Also, it can cause neutropenia, anemia, and other hematological side effects. These are summary of the different induction agents. with their source, dosing, efficacy, and tolerability. So you could see, for example, that thymoglobulin and ATG ferzinase, for example, are very effective, okay? But their safety profile is not that great compared to IL-2 receptor antagonists, which are less effective, okay? But they have favorable safety profile. So maintenance immunosuppression. We'll start with steroids, and I think everybody knows about steroids because they are used in a wide variety of diseases. Okay, you know the old saying, if the reason is unknown, use cortisone. So they work. We don't know how they work in many of the diseases, but they do work. They have bad side effects, and these side effects are either chronic or acute. These are considered one of the oldest immunosuppressive agents. They have complicated mechanism of action, but ultimately they affect the IL-2 release, not IL-2 receptors like IL-2 receptor blockers. So they inhibit IL-2 release, and which is important for T cell and B cell activation. Again, they are used as induction, maintenance, and treatment of rejection. We use methylpred as IV initially for the induction or for treatment of rejection, and then we switch the patient to oral after a few days, and then we continue oral and we taper steroids. Again, depending on the organ transplanted, we could take the patient completely off steroids, and in certain diseases or certain transplants we cannot. But the main goal is to reduce steroids to the minimum tolerated and effective dose. They have many. Now we use prednisolone and prednisone. Does anybody know the difference between both? Which one is the prodrug? So prednisone is the prodrug which gets converted in the liver to the active prednisolone drug. So there is no difference between them in terms of efficacy. There is no difference in terms of dosing. So 1 milligram is equivalent to 1 milligram. However, prednisone is more expensive than prednisone. So we tend to use prednisone in general. There is no difference. Prednisolone usually is reserved for patients with significant liver disease where they cannot convert. So you give the active one. It's important also to know the different potency of steroids, especially when you want to convert patients from IV to oral, or patients on maintenance dose and you want to switch them to a different organ. So for something like methylpred is usually 0.8 versus prednisone, which is 1 milligram. So it's 80% the potency of prednisone. And cortisone also, hydrocortisone, cortisone, dexamethasone. So it's important to know the different potencies. Also, with steroids, it's important to know the mineralocorticoid activity. These are the three main things about steroids to know: the different dosing or different potency, the mineralocorticoid activity, and their uses, because certain steroids are reserved for certain indications that you cannot substitute it with another steroid. Some of them, they have antiemetic activity or property like dexamethasone. You cannot use methylpred, for example, instead. Certain types of infection like meningitis and so forth. Adverse events, we have chronic or long-term, and we have acute. Acute include, can somebody tell me any of the acute side effects? Acute side effects of steroids. Rash? Acne, la. Acne takes time to develop acne. Moon face takes time. Edema, yes, if they have mineralocorticoid activity, but يعني it takes time usually. Weight gain is long term. Hyperglycemia, yes. So hyperglycemia is an acute and it's chronic. So acute we call it hyperglycemia. Chronic we call it diabetes. So if they are on long-term steroids and they develop diabetes, it's because of the hyperglycemia, continuous hyperglycemia. Yes. Bruising, yeah, easy bruising or wound healing problem. That's an acute issue. Also, it's chronic as well. Patient is on long-term. Other acute.
Hypertension.
Hypertension, yes, can happen. What else?
Mood swings.
I can't see.
Bone mineral disorder.
Bone mineral disorder. That's long term. That's long term. Talk about osteoporosis, something like osteoporosis, but that's long term. Acute, think of hyperglycemia, hypertension, leukocytosis is very important. That's an acute side effect. Hallucination and mood swings. Also, we see it in our patients because we give them high dose initially, so that's an acute. Chronic, everything you mentioned, okay? Acne, wound healing, peptic ulcer disease, cataract, they're very nasty drugs. They work good, but long term, that's why we think of always minimization. Try to minimize steroids as much as possible. Hyperlipidemia, osteoporosis, all of these are chronic side effects. Okay, CNIs or calcineurin inhibitors. These are the cornerstone of current immunosuppressive agents in organ transplant. Okay, so we could minimize, and in many cases we could avoid steroids. Okay, but we cannot avoid CNIs in most organ transplants. Actually, studies that attempted, or people who have attempted to minimize CNIs, not minimize, sorry, avoid CNIs, have resulted in significant risk of rejection. We're talking about 40-50% rejection here, we're going backward. We could minimize them though. So calcineurin inhibitors, talk about tacrolimus is the most important, well, it's not the most important, but I mean, it's the most widely used medication now in multiple organ transplant. It is a macrolide antibiotic. It doesn't have antibacterial activity though. From Streptomyces species, it binds to FK binding protein 12, which results in forming a complex that inhibits calcineurin enzyme release within the T cell. So as you can see here, this is calcineurin enzyme, which is important in activating IL-2 receptor and ultimately signal 2 and then signal 3. So by inhibiting calcineurin inhibitor through binding to what we call FK binding protein. Remember this FK binding protein because we're going to talk about it later with the mTOR inhibitors. Both cyclosporin and tacrolimus inhibit calcineurin enzymes, but they do it differently. So cyclosporin inhibits what we call cyclophilin, and it forms a complex that inhibits the calcineurin enzyme. But tacrolimus inhibits FK binding protein, okay, which inhibits calcineurin enzyme. The dosing is variable depending on the level, as Dr. Bilal mentioned. That's why we need to apply close therapeutic drug monitoring. We have different targets for each organ transplant, for each stage post-transplant, okay? And the role of pharmacists here is very important, okay? It has multiple side effects. They both have similar side effects. So if you know one, you should know the other. They are both nephrotoxic, but tacrolimus tend to be more nephrotoxic. They both cause hypomagnesemia, but we see this mainly with tacrolimus. They both cause hyperkalemia. This is something unique you need to remember. So they cause hypomagnesemia, but hyperkalemia. And hyperglycemia, tacrolimus tends to be more hyperglycemic than cyclosporin. They all cause neurotoxicity, including headache, tremor, up to seizures, and it causes alopecia. So that's unique to tacrolimus. and this is an important cosmetic side effect, especially for females, young females. And this also can affect what Dr. Dalal mentioned, their adherence to the medication, because they see that they're losing their hair. And we've seen some patients who are not compliant with tacrolimus because they know that it's causing hair loss. And there are ways of addressing this issue, by the way. So, I'm not going to talk about its pharmacokinetics because it's complicated, but the most important thing is it's metabolized in the liver by the microsomal oxidation system through the cytochrome P450 3A4 subsystem, which is the main subsystem of the 450. Also, it's metabolized by the 3A5. Also, it's affected by what we call P-glycoprotein efflux pump in the intestine and in the liver, if you're familiar with this. So it has multiple pharmacogenetics implications. So those patients who are wild-type CYP3, 3A4 or 3A5, P-glycoprotein, they might have different absorption, they might have different metabolism, okay? Drug interaction is very important, and this applies for both cyclosporine and tacrolimus. Because it's metabolized, it's substrate of 3A4, any enzyme inhibitor or enzyme inducer of the 3A4 affects its metabolism. So enzyme inducers or enzyme inhibitors like azoles, antifungals, macrolides, okay, antibiotics like erythromycin, protease inhibitors, calcium channel blockers, all of these are enzyme inhibitors. So they lead to increased level of tacrolimus and cyclosporine. Drugs that induce 3A4, like rifampin, phenytoin, phenobarb, they actually decrease its level. You really have to adjust. This is very important because we tend to use these medications in our transplant patients. Okay, so patient develops seizures, we have to put them on phenytoin, we have to adjust. Patients that has TB, we have to use rifampin, we have to adjust. Patients who has fungal infection, we use azoles, we have to adjust. So this is very important. Also, one very important side effect is their interaction with statins or H&G coenzyme A reductase inhibitors, like simvastatin, pravastatin, and torvastatin, and others. Pravastatin not really, but pravastatin doesn't really undergo the 3A4. So simvastatin, atorvastatin, and rosuvastatin, they undergo the cytochrome P450 3A4 enzyme as substrate. So they are metabolized by the same enzyme. So there is some competition for the same enzyme, which results usually into elevation of statin levels because they do not get metabolized by this 3A4 system, okay, enzyme. So they do not get deactivated. So you have more statins, free statins in the blood, which leads usually to development of side effects of statins, including myopathy up to rhabdomyolysis. And that's why the recommendation is to start with the lowest dose. So you start actually with the half starting the dose in normal patients. So for example, simvastatin, what's the starting dose of simvastatin?
10 and 20.
Okay, 20. It used to be 10. Okay, it was changed recently to 20. So that's the starting dose of simvastatin, right? So if you want to start in patients who are on cyclosporine tacrolimus, then you use actually half the dose. You start with 10. We don't always do this because we monitor the patient, and it depends on but it's very important to know the side effects. It's not that they affect cyclosporine or tacrolimus. This is a common misconception. People think that they affect cyclosporine and tacrolimus levels. It's the opposite. There's a new formulation. These are BID agents, cyclosporine and tacrolimus. There is a new formulation of tacrolimus called Aldagraph, recently approved. It's given only once a day. It's marketed as to improve patient adherence, and it has been shown to improve patient adherence. However, there are some questions about its efficacy, especially increased risk of acute rejection in kidney and liver patients in the first few weeks. And we monitor it the same way through trough level of tacrolimus. Cyclosporin is very similar in mechanism of action. So instead of binding to FK binding protein, it binds to cyclophilin, but it inhibits calcineurin enzyme. It has the same side effect profile, same drug interactions, okay? Same drug interaction with some differences, same adverse drug reactions with some interactions. Sorry, what did I say? So same drug interactions with some differences, and same side effects with some differences, and we're going to touch on them. But it's also very important to know that there are two formulations of cyclosporin. There is the old formulation, the one we talked about, 1978. It's called Sandimune. And there is a newer one in the 1995 was introduced the first time. It's called the improved microemulsion formulation. Cyclosporin comes in capsules dissolved, filled with oil, soybean castor oil, and it's the cyclosporin is dissolved in that oil. So absorption of oil-based substances is dependent on body for emulsification. Your body cannot absorb fat as is. That's why people who underwent cholecystectomy, for example, they advise them to avoid high-fat meats, right? Because they will have difficulties in absorbing fat because they don't have enough bile. So its absorption in this formulation is dependent 100% on, not 100%, but significantly on the availability of bile. In liver transplant patients, the bile production varies, so the absorption varies, and there is erratic absorption. The new formulated one, microemulsion, comes as a microemulsion inside the capsule itself. So it's less dependent on bile for its absorption. And the bioavailability is better. The consistency of absorption is better, so it's less erratic. Still, a lot of other factors that play a role, as we mentioned. P-glycoprotein efflux pump, for example, is an important factor for absorption of cyclosporin. But again, it's less erratic, it's more bioavailable than the old Sandimune. The new formulation called Neuron. Unfortunately, in our country, I don't know about other countries, it's confusing because if you look at cyclosporin, those of you who work in hospitals, if you look at cyclosporin box, you'll see that it says Sandimune Neuron. And the one we have, I hope everybody has, is the Neuron one. Once you have Neuron, that's the microemulsion formulation. So make sure that you have the new improved microemulsion formulation because it has better absorption. And they are not interchangeable, so you cannot use this and then switch to the other. You could switch, but you switch and you stay. Okay? And switching is one-to-one, unfortunately, even though that's the recommendation of the manufacturer, even though they are not bioavailable the same way. Dosing same variable. Most important thing here is side effects. So we mentioned that they have similar side effects but different incidence. So nephrotoxicity, as we mentioned, less than tacrolimus, causes hypomagnesemia, less hyperkalemia. It causes more hypertension than tacrolimus, more hyperlipidemia than tacrolimus, but less hyperglycemia than tacrolimus. It can cause ST headache, tremors, and others, and it causes something unique, gingival hyperplasia, and finally, it causes hirsutism. If you remember, tacrolimus causes alopecias. Okay, so this is different. One of the ways of handling alopecia is to switch patient to cyclosporin, but then they develop hirsutism, and then they come back to you, and complain of, especially in young females. Same metabolism, same drug interactions with statins and enzyme inhibitors, enzyme inducers. The only difference in terms of drug interaction is cyclosporin affect the metabolism, not the metabolism. Well, it affects the hepatic, enterohepatic recirculation of MPA derivatives like mycophenolic acids. So mycophenolic acid actually goes into into enterohepatic recirculation, gets glucuronidation, and then it gets reabsorbed and deglucuronide to MPA again. So cyclosporin blocks this. Okay, so it reduces cyclosporin MPA, free MPA level in the blood, while tacrolimus does not do this. Okay, so that's why we tend to use lower doses of CellCept, like mycophenolate or MMF we call it, less dosing with tacrolimus than with cyclosporin. Also, it interacts with sirolimus, and FK does not, and that's why we separate cyclosporin and sirolimus, while we do not separate tacrolimus and sirolimus. I'm not going to talk about pharmacogenetics because that's beyond the scope of this. Antiproliferative MPA derivatives have mycophenolic acid, mycophenolate mofetil, and they inhibit inosine monophosphate dehydrogenase enzyme, and this enzyme is important for de novo synthesis of purine. Okay, and T cells are dependent on de novo production of purine for DNA synthesis, while other cells, they can take purine from food. Okay, so it affects actually mainly T cells, but it has also side effects on other cell lines. That's why it causes anemia, leukopenia, and thrombocytopenia. So Myfortic and CellCept are equivalent in terms of safety and efficacy, despite some marketing, tries to convince people that Myfortic is more safe, especially with the GI side effects. But for all practical reasons, they are exactly the same in terms of side effects. They have multiple side effects, mainly GI side effects: nausea, vomiting, diarrhea, abdominal pain. Hematological, like leukopenia, thrombocytopenia, increased risk of infection and malignancy as well, especially skin cancer. We do not, it's available. Therapeutic drug monitoring for MPA derivatives is available, but it's questionable in terms of clinical significance, so we don't really monitor it routinely. There is equivocal data of its importance on risk of rejection and side effect, so it remains controversial. Imuran is actually an old drug. It's still a good drug, cheap. It has similar side effects to MPA derivatives, less GI side effects, but still has leukopenia and thrombocytopenia effect. And also it has hepatotoxicity more than MPA derivatives. Usually it's used for patients who do not tolerate CellCept, or patients who have certain drug interactions. One important drug interaction with Imuran, though, is allopurinol. Those patients who are using allopurinol for gout and using Imuran or azathioprine at the same time, it's very important to reduce the dose of azathioprine to 75%. So you give only 25%. Otherwise, the patient will have significant hematological side effects. And the mechanism is through xanthine oxidase enzyme, because allopurinol is an inhibitor of xanthine oxidase, which is important in deactivating 6-mercaptopurine, which is the active form of azathioprine, into its inactive metabolite. So if you block that enzyme, it will not be deactivated. There will be much higher 6-mercaptopurine and side effects. So this is the mechanism of the interaction. mTOR inhibitors like sirolimus and everolimus. Initially, when they were introduced, we were really happy because they work on, they bind to FK binding protein 12 again, but they form a different complex that does not inhibit calcineurin inhibitor. It actually binds to inhibit what we call mammalian target of rapamycin, and ultimately inhibit cell cycle in the S phase. So ultimately no DNA synthesis. When they were introduced, sirolimus in particular, we were really excited because we thought that this does not have the nephrotoxicity side effect of calcineurin inhibitor, which was a challenge and still a challenge for all of us. But they turned out to be not as effective as CN9s, so they cannot be used as mainstay like CN9s. Statins also are effective, and they interact with cyclosporin, so they increase the level of cyclosporin, increase the level of sirolimus. That's why you need to separate. The last class is T-cell cross-stimulation blockers, or CTLA4, cytotoxic T lymphocyte CD4 antibody or blocker. They inhibit the CD8 and CD86 in the on the antigen-presenting cells, which leads to inhibition of CD28 on T cells. And this inhibits the co-stimulation, what we call T-cell co-stimulation, and ultimately, activation of T cells. This agent, despite that it's maintenance agent, is given actually as parenteral. So IV, it's given IV. It's given once a month for maintenance, but it needs induction. So you give usually 10 milligram per kilogram for now, and then 2 weeks, and then 4, 8, 12 weeks, 10 milligram per kilogram. Then you switch to 5 milligram per kilogram every 4 weeks. So the patient has to come to the hospital to receive this. And this is a maintenance therapy, it's not oral. So it might work for certain patients who have difficulties with timing, and it might work. It might be challenging for patients who have to come every month and restricts their movement. It has its advantages, but it also it's newly approved, so we don't know much about its long-term outcomes in terms of side effects and efficacy. The most important thing is it can increase the risk of malignancy and, most importantly, infection. That's why it has to be used in patients who are EBV seropositive. If they are seronegative, the risk of EBV infection is significant. So it's contraindicated in EBV seronegative patients. Also, it can reactivate TB, hepatitis B, CMV, you name it, polyoma, BK, and it's only approved in kidney transplant patients. So it should not be used in liver transplant. Actually, the studies in liver transplant have shown increased risk of graft and patient loss. So it increases graft loss and increases patient death. So it should not be used in liver patients. And it has a black box warning about its infection rate and others. I think depends on the time. So these are the classes. I have some cases, but I don't think we have enough time to go over them. These are different, the different sites for different maintenance immunosuppression agents, and this is summary of the toxicities available with different maintenance immunosuppression agents that you need to keep in mind. These are some of the new agents that are in the pipeline. Some of them have stopped in phase 2 studies, some of them are still ongoing. Abatacept, which is similar to CTLA4 blocker, ifalizumab, and Efacept, voclosporin, which is still in phase 2, actually stayed in phase 2 for quite some time, and some other agents. This is a figure that shows changes in immunosuppressive, maintenance immunosuppressive agents use over time in the United States. So you can see increased utilization of mycophenolic acid, for example, and more use of sirolimus in the early 2000s. This figure actually went down in early 2000. These are different protocols of immunosuppressive agents. So each center usually develops their own protocol for induction, maintenance, and treatment of rejection. And it's center-specific, your actual patient population, as well as the level of evidence available in certain patient groups. You have to develop a protocol for each organ, okay? For each patient population, adult and pediatrics are different, and for each cases, so patients with certain underlying diseases, patients who are highly risk, highly sensitized, low risk patients. So it has to be really comprehensive and customized to your patient mix. So different cases, so I think we have enough time. I don't know what's next. I took 10 minutes extra. Okay.